I've been told by my dear colleague Jody Palaha that I need to treat these next two guests like rock star royalty, because in the world of research they are. So we are very honored and excited to have you both with us today, and I'm going to read a little bit about just how accomplished these two individuals are. So Dr. Glasgow is a visiting professor in the Department of Family Medicine and Associate Director of the Colorado Health Outcomes Program at the University of Colorado School of Medicine. He most recently was Deputy Director of Implementation Science at the Division of Cancer Control and Population Sciences at the U.S. National Cancer Institute. That had been a really big business card. Dr. Glasgow is a behavioral scientist who has worked on many transdisciplinary research questions, including worksite health promotion, primary care-based interventions, and community-based prevention programs involving community health centers and Native American tribes. He has researched issues ranging from smoking prevention and cessation to chronic illness management, patient-provider communication, use of interactive technologies in healthcare, quality improvement, and guidelines adherence. He has published over 400 scientific articles and received the Society of Behavioral Medicine Award as Outstanding Scientist. Dr. Glasgow is particularly interested in patient-centered and team-based intervention approaches for complex, sticky problems. For example, developing feasible and efficient ways to assist primary care in dealing with the wide range of health behavior, mental health, and other risks faced by their patients, or in helping patients with multiple chronic conditions manage their conditions and navigate the complex systems of illness care silos with which they have to contend. His more recent work has focused on public health issues of enhancing the reach and adoption of evidence-based programs using the RE-AIM planning and evaluation model. Dr. Cohen is an associate professor in the Department of Family Medicine at Oregon Health and Science University. She has been developing her skills in qualitative methods for more than 20 years and has spent more than a decade studying primary practices with a focus on clinician-patient communication, practice change and improvement, and health information technology use. Dr. Cohen has expertise in a range of qualitative methods and approaches, including interviewing, observation, and conversation analysis. Dr. Cohen is a highly skilled analyst, and she has experience supervising qualitative teams in data collection, management, and analysis of qualitative and mixed methods data. Dr. Cohen uses her qualitative expertise on mixed methods teams to look at how improvements are implemented in primary care practices, to identify what changes are made, and to compare the effectiveness of observed practice change on process and outcomes measures. She has been a principal investigator on several federal and foundation-funded grants, leading mixed methods teams to understand and tackle the complicated problems related to implementing and disseminating new innovations and important quality improvements in primary care practice. Her work has focused on comparing the effectiveness of approaches for improving prevention services, health behavior, and behavioral and mental health care in the primary care setting. We truly are so excited to have you. Please come and join us on the stage. You're all in for a treat. Thank you.
Well, good morning, and Jennifer, thank you for that overly generous introduction. A little slightly embarrassing. I want to share with you that this is my first CFHA, but I've got to tell you it's been an incredible experience, and I feel especially privileged to be here on your 20th anniversary and to learn a bit about your history. I've heard just a few of the war stories anyway, but I look forward to hearing more and enjoyed CJ's synthesis that was involved there. If we could go ahead and have the slides up, thank you. And I think I need the clicker, Deb, if I could.
Yes.
The reason we both came up here is we're going to try to do something a little different this morning here. Given both your focus on integration and collaboration, and the fact that our goal really is, as you can see on the title here, to try and convince you how implementation science and evaluation are key parts of integrated care to getting to the AAA. We thought we'd try to integrate our talks and go back and forth here rather than doing the usual sequential one at a time talking heads. So I'm going to start out very briefly, talk with you about implementation science, and how it can be relevant to integrated care, why you might want to think about it as one of the future directions of the vision that was so nicely just laid out for you. Then Deb will talk with you about evaluation, and especially about learning evaluations and how that can really help us get to the triple aim. I'll then come back, or actually we're both going to share thoughts about population health aspects of the triple aim and technology cooperating with us. We're going to hear from some patients on some videos of their experience, that aspect of the triple aim. Then we'll summarize and should have plenty of time, I think, for some interaction and give and take here. So implementation science is designed to address what I call the pragmatic challenge. So I was interested in the comments this morning, as well as Dr. Beardsley's talk yesterday, which I thought was just great. And the key issue there is that much, as most of you are aware, much research is not really relevant to real-world practice. The reason for that is that it's conducted under such carefully constrained conditions, ideal conditions with such selected populations that it makes it difficult to translate that to real-world care. I've been privileged in my career to work with two great Larry Greens. The one that's so well known to you, and also there's another one that some of you may not be as familiar with, what I call the public health Larry Green, now from UCSF. And this is one of my favorite quotes from Larry W. Green, which is, if we want more evidence-based practice, we need more practice-based evidence. So with that, let me just share a slide with you, and I hope you can see this. It's a little faint from here, but rather than boring you with a formal technical definition about the factors and the processes that are involved translating evidence-based interventions into the real world, I find a picture or a visual more helpful to think about what's at the heart of implementation science and why you might consider as relevant to integrated care. If you look on your left, yes, it's your left also, you'll see there we have an intervention, and this goes back to something Dr. Beardsley talked about in terms of at the center is kind of the critical element or the core component of an intervention. But when we deliver a program, it's embedded in a whole lot of other things, a wrapping in terms of how we present it and packaging and marketing. On the right-hand side, you can see is the context, and we could have had 10 or 12 circles here, concentric circles, rather than just the ones you see there, but embedded really within the community, an organization as a practice, and then the staff that deliver a program. And finally, at the bottom is the team that's working in partnership to evaluate the intervention, the researcher, the evaluation team, and how they do that. But what's really critical here are the arrows. It's not the circles and the things there, but it's how they come together and those words of fit and partnership and what's appropriate. So rather than trying to find the one best intervention or the best setting or practice, what we're looking at is alignment or fit and how what works the best for a particular situation. want to say just a word about and then give you a quick example of a model from implementation science. And you might ask, why would you want to be interested in something as ivory tower academic as a model or a framework? Well, I think the reason is that frameworks can be helpful for suggesting, helping us what we need to key on for success if we want to be successful at addressing the triple aim. And it can be useful, a model both for planning as well as understanding the results that we get. Some people, critics, have accused implementation science of having more frameworks or models than they have empirical, well-done studies. I don't think that's quite the case, but there are a number of them. But I'd like to just share with you the outlines of one this morning that Deb and I will go back and forth and use during our talk. That model is called the REAIM model that Jennifer briefly mentioned to you. REAIM is an acronym that's short for the goals, really, of, I think, what we want to do, both in the triple aim and I think much of what you want to do with your integrated care interventions, and that is we want to increase reach, effectiveness, and then turning to the settings in which we want to demonstrate this work and translate it into practice. We want to increase adoption, implementation, and the maintenance. And you might help me here to know just how quickly to go over, because I don't want to bore you, but I don't want to lose you either. If you're familiar with the REAIM framework, could you raise your hand so you see? So what's interesting, I have a side that's kind of about what I expected a little more, but there's a side bias. So I don't know. All the people over here on this side of the room seem to be familiar with it, and less so out there. So I don't know what that means. I'll ponder that. But let me just quickly go over, in terms of personalized medicine, questions you might ask about integrated care. Then we'll give you some real-world examples of applying REAIM. But how this might drill down that you might ask is, first of all, well, what percent and types of patients are reached by integrated care intervention, and who among them, really benefits in terms of the effectiveness in improving what outcomes, and this is an important part, with what unanticipated consequences. I'll return to that later, but I think that's a key issue. And then turning to the kind of the setting or the contextual factors, we also ask about, well, what percent of types of both setting and staff, are willing to attempt or to even try to adopt an approach? How consistently are different parts of integrated care delivered, and at what cost to different parties? And finally, how well are both the intervention components and the effects of the intervention maintained? So the last thing I'd like to do before handing it off to Deb to give you some concrete examples here is to just come back to the importance of context and how REAIM tries to broaden the focus a bit, to focus not only on internal validity and methodological rigor, but also to focus on external validity or the generalizability of findings. Through evaluating things like program adoption, implementation, and sustainability. And we really think that one of the key ways to close the gap, or some people, including the IOM, have called the chasm between research and practice, is to suggest some standard reporting criteria. I was privileged to work with Roger Kessler and C.J. Peak a little over a year ago on a paper where we tried to drill down to the essence of REAIM. If you wanted to use it, how might you, what would be kind of the full use of it, using some of CJ's concepts and things of a paradigm case, which was a great experience. But we do feel that the REAIM approach can be used to design and as well as evaluate and report on interventions. And the key focus that I want to leave you with for now is it's focused on contextual factors. And as I went through the example, kind of the who, what, where, why aspects of it. And with that, I'm going to pass the baton, our mini baton, back to Deb, who will talk with you about now specifically how we think this can be relevant to integrated care and bring us back to the triple aim focus.
Thank you. I feel like we should do a fist bump at these transitions. There's one other thing that I should point out. I'm sure most of you are familiar with the Beatles. My husband and I often argue about which was the biggest coattail rider in the Beatles. Was it Ringo Starr or George Harrison? And you can decide which one was for yourself, but I can assure you I am a coattail rider today. So I'm going to talk to you a little bit about a program called Advancing Care Together, or ACT. And one of the reasons why I think I'm a coattail rider is that Russ is being very modest, I think, about the RE-AIM framework. You know, we all sometimes recoil from the ivory tower of theoretical models, some more than others. I'm probably pretty far along on that spectrum. But the RE-AIM model is a really useful, pragmatic model for doing on-the-ground empirical work. And that's the reason why we chose to use it in ACT. So our work has really been informed by the work that he's done. So Advancing Care Together is a program funded by the Colorado Health Foundation. In it, there were 11 practices funded. 9 of them were primary care practices. 2 of them were community mental health centers. They all were asked to focus on integrating care. Now, this was a demonstration project, and that's important, and I will talk about that a little bit more. These practices were not paid a lot of money to try out an intervention that was going to go away once it was over. They were given a paltry amount of money to do something that they were going to sustain for a long time. And what we're going to talk about is some of the small steps and important steps, what Rusty referred to little steps earlier on, these little steps that are monumental in a program's ongoing development. It's hard to, it's really hard to sort of see your slides. I'm realizing why people were standing over here earlier. It's okay, I'm not tall enough. Anyway, we had the privilege to follow these folks on their journey. We watched 11 of them from the beginning until the end, and don't worry about it. Don't worry about it. It's all good. We watched them from the beginning until the end, and I'm going to tell you a little bit about what we did to watch later on. So let me talk to you about this idea of a demonstration project. So we knew going into Advancing Care Together that there was good evidence to suggest that integrating behavioral health and primary care worked. We knew from rigorous RCTs and systematic reviews that you got better outcomes when you treated physical health problems and mental health problems together. So we didn't have to do that in ACT. These practices already knew that bit of it. We also knew that patients' experiences improved and provider experiences improved when integrated care was being delivered. Again, our program didn't need to establish that. That was already established. We also knew that costs could be lowered when integrated care was delivered to patients. We knew that when diabetes and depression was treated together, that there were large medical savings. And this work actually comes from some work done by Steve Mellick. And he was kind and gracious enough to provide these data to us. And he is an actuary extraordinaire. So I want to thank him. And if you don't know him, you should meet him. But we knew that pathways for diabetes and depression, when they were integrated, saved money. We knew that the IMPACT program, when focused on depression, saved money. There was lots of evidence that lower costs were achieved when physical health and behavioral health problems were addressed together. And these are just some of the findings about savings that he's been able to show about when comorbid chronic medical and behavioral health conditions and insured populations are treated together. And he's an actuary, so he gets to look at these things in really large groups of people. So this is really good data, and we know that this saves money. So in ACT, we didn't have to prove that. So that gave us a lot of degrees of freedom. So what do you do when you've got 11 clinics who are trying to actually change practice? What do you need to know? And the things that you need to know are how to do it. You know, when you think about in your own practice, what are the challenges? You read these articles and you know that it saves money and you know that it increases patients' outcomes and their experiences of care, and you know that your providers like it better, but how do you do it? How do you work on the ground to integrate this in your clinic? And that's where the REAIM framework was really helpful to us. So we not only wanted to understand implementation, which is the I in REAIM, how do folks implement this? We also wanted to know when they implement it, how are they doing in terms of reaching the target population? And we're also looking at things like effectiveness and maintenance, but they were a lot lower down on our priority list because there was literature already established in these areas. So data monitoring is essential, and data monitoring is really, really important, not so much for us as researchers, although we wanted them to do it as researchers, but what we learned was that this data monitoring turned out to be incredibly important to the 11 clinics that we were working with. They were, and I'm going to talk with you a little bit about that. So let me tell you about the data that we did collect, and I'll tell you a few stories later on about why it was so important. So at baseline, we wanted to understand the clinics and the practices, just what their characteristics were, who they were owned by, how many people they staffed, those sorts of things. Then we wanted to watch their journey over about 3 years, and we did this by collecting some key documents that they created, from grant proposals to other protocols and workflows that they created. We used something that we've created called an online diary, where folks wrote in an online journal every couple of weeks about what they were experiencing in terms of as they were implementing their innovations. And this is useful because a lot of times what happens in qualitative work is, you let folks ramble along for 3 years and then you go back and you interview them about, what they did. And at that point, all they remember is either the huge successes or the catastrophes. And usually it's the catastrophes. And we really didn't want to know that. We wanted to know the mundane, everyday, basic things that folks go through. So we really encourage folks to post on a diary more frequently. And when that didn't work, which it doesn't always work for everybody, we get on the phone and we find out what's going on. And we also did site visits. So we go in and we walk in and we touch and we meet and we see what's going on in each and every one of these practices. And as I explained yesterday, these are extensive visits where we often take a team of 2 to 4 people and blanket a clinic, where we watch every facet of their operations from, think about the beginning of where a patient walks in to the end of where a patient walks out. We try to get an opportunity to watch all of it. And as Rose said so beautifully, our sincere thanks have to go out to the practices and the patients that really let us do this work. It's not easy. And if you think, would you like me in your visit? When you go to your doctor, you can really think about the amazing contribution that patients make. I think some of them enjoy it. I think some of them don't. And there are parts of visits that we don't enjoy either that we try to leave for. I can assure you. People go in to do qualitative health research because there's parts of visits they don't really like. And we assess reach. So reach is an interesting thing for us. It's both a research measure, but it also has emerged and act as a clinically relevant measure for the teams. So what we were looking at was the percent of target patients screened, those that were screened positive, and then those that were screened positive, the percent that reached services. And what was very interesting about this in a number of the ACT practices was that there were a number that felt like they were working really hard. And integrating care is really hard work just to get the people in place and the workflows. But I have to tell you, reach was a come to Jesus moment for a number of these places, where they would take a look at their numbers and say, how is it we only reached 35 patients this quarter? And it was a really great moment to say, well, what are you doing? How are you getting to these folks? How are you screening them? And for some folks, they didn't want to reach more than 35. And I'll talk about that in a minute, because they didn't have the resources at the other end to handle more than that. But it's a great guide. It's a great guide for folks on the ground once they're starting to get to collect it. And then we are assessing effectiveness through patient outcomes, expenditures, and utilization. But I'm not going to talk to you about those today for a couple of reasons, the main one being we don't have those data yet. So I just wanted to show you what we think about when we think about learning evaluation. And this is a pretty complicated picture, but let me see if I can walk you through it. So we really try to follow the journey of the clinics. So the dotted line around each box represents a clinic, and those boxes can show that there can be any number of them. The circles at the bottom show sort of these short, continuous quality improvement cycles that we see that each clinic goes through. And they go through them at their own pace. And Rusty, this is exactly what you were talking about in terms of these short but important little steps that you take in the change process. So what we do is we try to collect qualitative and quantitative data along that change period, which is relevant to the clinics. And every quarter what we did was we would review those data with them in a learning meeting. And those were really fun. So those are the points where they first got to see the data pulled together that they were collecting. And they became storytelling sessions and therapy sessions where we could just say, so tell me about that 35 patients that you screened in the last quarter. And they're like, wow, I didn't realize it was 35. You know, and then we could talk through with them. Well, how do you screen patients? Who's doing it? How do you get those patients that are positive to the next person? And it just was an hour or so where they could talk together and with us about what they were learning and seeing with their data. And we did that with all 11 practices. And some of them had more cycles than others. And we try to then extrapolate those data across the 11 to look at cross-case learnings. So this is where we get to do our research fist bump.
Research, I'm getting
I
that
know.
image in my head here, so we'll see. We're going to switch focus back a little bit and start making this more quickly interactive too. But we'd like to focus now on population health aspects and how REAIM is related and can help us look at integrated care through that lens. The two key aspects of REAIM that are distinctly relevant for population health are reach and adoption. I'd like to just take a minute to go over this and share some of the lessons learned from applying REAIM in a number of studies here. And so just to lay out the parameters here, REACH focuses on two key things. One, the participation rate that Deb has talked about and has some wonderful examples in a second for you among eligible individuals, but also equally importantly, the representativeness. Who is it that you're reaching there? And then adoption is very, very parallel, but often the source of a lot of confusion. It focuses on similar things, participation rate, but now we're up a level or two and we're focusing on the settings, the practices, and the staff within there who participate. And then secondly, how representative of them are there? What types of backgrounds and skills do you need to get people to adopt something? Just a couple key lessons that we've learned from a fair amount of experience applying this is that what I like to say is the critical importance of focusing on denominators. Both in practice and in research, we often focus on the numerator. That's who comes in, who we see, who participates in an evaluation, but we don't focus on the broader, the overall population or the focus. We found that reach and adoption are frequently confused, and I think maybe that's obvious because it's similar principles, but it's at a different level that we have here. So again, the reach focuses on the patient or the individual level, adoption on more the setting and the staff implementation level there. And the final thing is that we have, what we're trying to do particularly on most evaluations, is to give us a ballpark figure of the REAIM estimates. And sometimes people get hung up if they don't have like a perfect registry or they don't know the exact denominator to do that. What's important is to get an estimate, and there are an increasing amount of data sources that you can do that if you don't have the exact one. But it's not the difference between 15 and 16%. Okay, reach, but it's we want to know, are you reaching 5% or 50 or 60% of the key folks that you're targeting there. And with that, just kind of to keep in mind, I'm going to turn it back to Deb to give you some examples actually focusing on reach in advancing care together.
Okay. So let me tell you a little bit more about advancing care together. So the first thing I wanted to talk with you about are the types of interventions that these practices implemented. And what you see on the slide is many of the components, and multiple of these components were implemented in these practices, but it included brief counseling in primary care, referrals to traditional long-term care, both within the clinic, with partner organizations, and outside the clinic. A lot of these practices were, for the first time, really trying to figure out how to do a warm handoff between a behavioral health provider and and a primary care clinician, and some of them were experimenting with joint visits, where both of those providers would be together in the examination room. So this is a graph that shows the different types of screening tools that the practices used in ACT. Now, we didn't dictate what screening tools that they could use, so when you think about our reach numbers that I report, you should sort of think about the screening tools as all being the same. We just counted was there screening or not screening necessarily in our numbers. But you can see they used a range of common tools, and I don't know if the font is big enough for you to read that, but PHQ-2, PHQ-9, GAD-7, they used a number of very common assessment tools, audit. So let me tell you a little bit about what REACH looked like, and I'm gonna bring up the whole screen, and then I'm gonna talk with you about some caveats. We've got data on this screen for an over 12-month period and an over 3-month period, and you can see that of the target patients as defined by these clinics, how they did in terms of screening and identifying screen-positive patients. Now, there's a few caveats. One is that this isn't all 11 clinics. It's about 9 and then partial data for 1. The other is that this data doesn't all come from the same time period. So when you're working with 11 practices that are working on a change and innovation, the first thing that you find out is they don't all change at the same time. So we don't necessarily want to collect data for somebody when they're not yet ready to change. So what we did is we chose the 12-month period where they were really most active and had gotten things going. As I mentioned earlier, they're all using different screening tools. They all define their target populations differently. And we did our, that wasn't ours to define, that was theirs to define. So there's a lot of variation in how they chose to screen patients. So there's a lot of variation in reach. Reach for one practice could be 2%, and it could be 9% for another, and I'm going to talk a little bit more about that. But one of the things that's striking to me was that, the NAMSIS data shows from 2010 that in primary care, the general rate of screening for depression is just over 2%, and these folks were screening patients at about 15%. So they really did a great job in terms of screening those patients, and of those that screened positive, we were at about half, which is interesting. So let me tell you a little story about screening. What you see at the top, those numbers between 80 and 90% screening rates, those are the practices that chose to systematically screen their patients. So if CJ Peek's lexicon identifies 3 categories or types of approach to identify patients in need of integrated services. One type is what I call clinical discretion. The second type is and the other end of the spectrum, I think, is systematic screening, where your organization comes up with an organizational protocol and system to routinely get folks identified, to understand the patient population, to find out what their needs are. That's what was happening here. So these practices had came up with a way that when a patient walks in the door, everyone was handed some kind of screener. It could be a paper screener, it could be a web tablet, but these folks were getting systematically screened. The bottom is one of the other categories that CJ talks about, clinical discretion. These are the folks that didn't necessarily use a PHQ-2 or PHQ-9, but somebody walked into their office, came in for a visit, and they started crying, or they were talking about something that was going on in their life. They screen their patient population at a much lower rate. Now, you're laughing, but there are some real decisions and some reasons why folks do this. So I'm going to tell you at least 2 stories, but I may weave in a third. We'll see how it goes. So because there's a third story about systematic screening. The reason why I bring up the screening issue is because it represents a really critical tension as you're developing an integrated care program. And the tension is this balance between how much I want to know about my population and its needs, and how much I have in terms of capacity to address that population and its needs. And there are organizations that we've learned in ACT that are actively choosing not to systematically screen because they don't either have or can't or whatever. They can't meet those needs. So they have made very purposeful decisions to rely on clinical discretion. The other side of that coin is that that's a reasonable and very pragmatic and logical strategy, but it's also a strategy, in my opinion, and I think everyone gets to choose their own position on this debate, but in my opinion, that's a strategy that makes it impossible for you to ever really know the full needs of your patient population. And one of the things that I've been really surprised at as we've watched some of these ACT practices grow and develop is that knowing the needs of your patient population is an incredible motivator and stimulator. It's really hard to know that your patient population has needs and then not figure out how to address them. So in my very unbiased way, I have this gut sense that the clinical discretion decision, while completely logical and reasonable, is a little bit of a move to stick your head in the sand. But you get to choose, right? Every practice gets to choose. So I'm going to tell you two stories. The first story is about a practice, and you'll see their graph on the left. This is a small primary care practice. A few physicians got their first behavioral health counselor during ACT. And this is a fabulous practice. So they had a behavioral health clinician that was new, and they had somebody that was taking on a new health coaching role. And what's great about this practice is that they know how to systematize things. So their green line on the top is their screening rates, and those were consistently pretty high. Now you'll notice that there was a little bit of a dip, so I'm going to simulate a little bit for you about what we talk about in these meetings with them. You'll notice that there was a little bit of a dip, and what happened during that dip was that this practice had decided that it was going to, one of the things that it was going to screen its patients for was BMI. And initially they decided that anyone that had a BMI greater than 25 was going to be, was going to be suggested to meet with the health coach. I veer towards that line, I can assure you. And they decided rather quickly that that was not the right line for BMI. So the dip that you see was then they accretes their BMI line closer to 30. But they did a really good job of systematically screening. It was a paper-based approach. They had somebody at the front desk do it. It happened to every patient when it was supposed to happen for the most part. The second line that you see is, is the screen positive line. So I've given away the joke. Sorry, I apologize. So it's not the dip in the green line, it's the dip in the blue line, which is the BMI line. When they shifted, you can see that their screen positive dipped dramatically. And then the red line is the referrals. Now this was really interesting. So at our first learning evaluation meeting with this group, they were extremely disappointed. These are high achievers. They were extremely disappointed in their referral rate, and they were committed to the fact that this was a documentation problem. And they went after that. And you can see that they actually made some traction in their referral rates just by helping clean up documentation. I think there was more than a documentation issue going on here, but in my experience, you can't suggest that there's more of a documentation issue going on until the practice actually starts to address the documentation issue. And the reason for that is they don't believe the data until the data are clean enough. And I think that they're now at the point where they realize that there's a few other steps along on this journey. And those have to do with the much more hard to tackle things, which is how do you get and maintain a consistent behavioral health provider in a clinic that's never had one before. And it's this realization that there's really cultural change on both ends, that it's not just your behavioral health clinician that's going to have to change their culture, but there may be some underlying changes that your primary care providers and other team members also have to make. And that's my take on really where this practice is now. They've made a ton of progress, and they've cleaned up a whole bunch of stuff. And now the next phase in their journey is really learning how to work with as a team. And they're on that path. So the second story is also this is a solo primary care practice, also committed to screening. And you can see that they've done an incredible job at really systematically screening. The blue line, which is their screen positive rate, we saw a big jump in that. Why such a jump in screen positive? You know, it turns out they took on another innovation in the time of doing ACT, and that screen positive rate is actually tied to, they started screening for alcohol and substance use problems. So they saw a big jump in a screen positive for that as they expanded and included another study. But this is the kind of stuff that you need to know when you're evaluating this sort of work. Why is the referral rate so low? Well, again, it's a combination of documentation and figuring out how to do integration, I think. The documentation is a big issue for this practice. They had brought in a new person who was really going to develop the infrastructure and had the capacity to help them document referrals to whomever, whether it was some brief counseling done by the primary care provider, whether it was to a BHC, or whether it was to an external agency. And they struggled with that, and then they lost this person. So they struggled with the documentation piece. I would say on top of that, too, this practice also struggled with another very common integration problem, in my opinion, which is getting a BHC that understands what integrated embedded care is. So this particular organization partnered with a community mental health center in their local environment to place a behavioral health provider in their clinic. And this person was used to delivering traditional behavioral health care and proceeded to do so in a practice that probably had a lot of patients who needed traditional behavioral health care. And she was only there part-time. So what happened was her schedule filled up immediately and there was no integration happening. But what's happened since then is even more interesting. So what's happened since then is that this practice, which is also amazing, has now hired a full-time, highly experienced integrated behavioral health provider who, in the first few months of shadowing the primary care clinician, realized this wasn't just a problem with the behavioral health provider. Turns out maybe the primary care provider didn't really know which patients an embedded behavioral health provider would be best appropriate for dealing with. And it seems to me that maybe the patients that were getting referred were highly complicated patients that needed long-term traditional therapy. And what this practice now needs to think about as its next iteration is, how do we build some relationships with folks outside of our practice for getting care to those long-term patients? Because if I send those to my embedded behavioral health provider, we're not going to have an integrated model anymore. How do we figure out a path for caring for those patients? And then how do we figure out how, as a team, to care for the patients that we think we can care for with a more brief, targeted, focused therapy approach in our clinic? And that's their next and really exciting growth step, I think.
Okay, we're getting there, folks. We're going to do a switch again now and focus on patient experience outcomes. And actually, in addition to just hearing from Deb and I, we hope to hear from some actual patients here that I hope you can see some of these elements in their own words. Maybe not quite so much researchese. But the key re-aim issues or dimensions that are relevant to patient experience are, first of all, effectiveness. And by that, we mean both the kind of the usual focus on what's the primary outcome of interest if you're working on pain, reduction in pain, improvement in depression, but also the broader outcome from a whole person perspective, a focus on overall quality of life and any negative outcomes that we might see. Secondly, maintenance, and here I've just focused on the setting level, but it actually, maintenance actually applies at both the individual and the setting level, to mean the individual level is just the longer term effects of intervention. But the key thing from a setting perspective is the sustained delivery, and I also underline there the modification of intervention, because we usually see some type of modification. Seldom is the initial initiative just continued in the way that it was originally. A few lessons learned that we have about effectiveness and maintenance is that, first of all, going back to that initial slide that I showed you, kind of the systems perspective, is that there's, I said often, I'd say there's almost always some type of unintended consequences that come up in addition to your main effects. Sometimes those can be positive, as similar strategies, both at an individual and an implementation level, can be used for new behaviors. Other times they can be not so great, negative unintended consequences. An important finding is the middle one there, is that some of the programs that have the greatest effectiveness, okay, actually end up having the lowest reach. So the lesson here is we need to take a broad perspective and look across all the dimensions rather than just focusing on one. And finally, setting level maintenance, I should say, first of all, it's seldom measured, actually, in terms of when we look at it, either in research or practice. When it is, it's seldom sustained, but almost never is the program or an initiative continued in exactly the same way. So what I'd like to do now, with the help of our AV folks, is hear a patient story. And Paul, I see you're back there. What I'm going to do is go through, I think we'd just like to, given the time, take one of the stories, if we could. So I'm going to do the first story, and we'd like to hear in the patient's own words their experience of integrated care. And we'll highlight a few things, but I'm going to skip the second story. So these are patients, real patients, who've given their permission well, I guess we're just going to do one Advancing Care Together clinic, and here's their story about effectiveness. This is Patrick.
Hi, I'm Patrick. This is my health story. I had the good fortune of 52 years, as I'm now 62, of what I consider to be perfect health. As an athlete, always an athlete. I don't remember an injury. I didn't get sick much. And I sold my business when I was prepared to become a competitive tennis player at age 52. And in a moment in time, on a tennis court, I ruptured a disc into my spinal cord and partially paralyzed lower half of my body. Then I became divorced. I don't really have a career anymore because it's all my money. I don't have the body anymore to speak of. And I'm broke. And I didn't go away for 4 years. And so I took my isolation into alcohol and began to use it as my coach, my friend, basically, as an alcoholic will tell you. So as my life unraveled, I came to realize how broken I was. I didn't expect that my doctor would be the person that walked in that I would open up to and break my isolation. As an MD, he's a straight line MD, all of a sudden he's different. And after we do all my vitals, we do this 6 deep things, this down with the
Okay, great. Well, I hope
That's
you, yeah.
So we should point out that Maribel Cifuentes and Linda Niebauer had a lot to do with creating those stories. So thank you. They're fabulous.
Yeah, again, there's others available.
Yeah.
The one that unfortunately we're not going to get to today is Sandy's health story, but we'll make links available to you here. But I think that was a really nice illustration, some of the key aspects of effectiveness and the ongoing issues of maintenance. If you notice, Patrick talked about too. It's not usually a straight line journey there. And with that, so we have time to interact with you with Paul's help. Thank you. It's beautiful. We're just going to mention a few key take-home points now to wrap it up, and then take any comments or questions that you have. We hope that you found something in here, regardless of whether you're in practice, policy, or research, for something to help you apply to as a kind of a lens to focus on using implementation and learning evaluation for integrated care to help us get to the triple aim. I do want to state that we've had a number of modifications of the REAIM model along the way, and it, like all models, I think George Block said this, all models are wrong. We're constantly learning on that. Sometimes they're helpful. There's some of the models are helpful at pointing us the right direction. We do really feel that ongoing, what Deb's called a learning evaluation, monitoring quality, learning from a range of data as we go along, not just waiting till it's too late, as Deb nicely summarized before, and telling about 2 years later what went wrong, but learning as we go along. Maybe one of the key things that we've learned, and I mentioned, gave you one example, is that the REAIM dimensions and many perspectives are interrelated. So you can't just do one thing and get one outcome, but there are downstream effects and interrelationships among all of the dimensions. And Deb was kind enough to add the last slide from her experience using REAIM and other things here, that in implementing integration evaluations, that REAIM somewhat has been found helpful. Anything else you'd like to add, Deb?
Good.
Okay, well, with that, we want to thank you, and I think we've saved enough time that we can have some integration. So thank you very, very much.
Hello? Is this working?
Yeah.
My name's Deb Gould. I'm in Yakima, Washington, and I've been teaching in family medicine for about 20 years, and started out with Paul Nutting and community-oriented primary care, and have seen this kind of get, I feel like, mainstream to population health now. So I've kind of watched this process, and I guess two things. I'm wondering if you have any influence on the HIT community, because that's been my biggest frustration, and my practice's biggest frustration is we can't get good data. So that's the biggest, that's one of our issues, both clinically and as a teacher. And if you have any suggestions about that. And then the second thing is that how is the REAIM model either complementary or different or better than the IHI Institute for Health Improvement, quality improvement models? Because I'm trying to integrate that into my curriculum, and I'm wondering, well, should I be refocusing on REAIM, or how do these fit together?
Handle that one.
Do you want to do try the first one?
Yeah, I'll try the first one. So we, in a separate study from ACT, we have been studying a small number of practices that are integrating behavioral health care in Oregon. And we have some funding from NIMH, and we went out to those practices using similar sorts of methods to understand what their health IT needs were. And what we learned rather quickly, and Rose Gunn is working on this project as well, what we learned rather quickly is that they don't really have tools, much like you described, to help them work with their patients, to document what they're doing. And in fact, there were a couple practices where the behavioral health provider would just put a text note in the primary care provider's note, which in my opinion was never to be seen again, probably. So what we've done is we've developed with an organization in Oregon called OCHIN, an EPIC-based tool, building on some of the work of Roger Kessler and Ben Miller and others, that actually is for the embedded behavioral health providers. And this tool is going to be pilot tested very soon. And we will start to think about how to spread and release that more widely. But it's pretty cool, you know, and I think what we've seen is that either somebody needs to help you build it, or you need to find somebody in your organization that can help you build templates for your EHR, because you're right, they're not out there. But when you think about building them, I guess the 2 cents of advice I would give you is focus on getting things to be able to come out as numbers and not put in as text.
Yeah.
So the extent that you can click on things that can then be extracted is going to help you not just with your documentation, but also help you with the measurement piece of it. That's how we've been thinking about it.
Again, I don't know we have any magic answers.
Yeah.
I think often some of the HIT things are example of unintended consequences that happen there. In terms of your question about REAIM and the improvement model, I really see them as compatible, and we've been involved in some projects looking at chronic care, really combining the two. I see in general the IHI model as more focusing on process and how do we get there, working with to individualize and specify that, particularly the notion of rapid learning and PDSA cycles, where REAIM focuses more on the outcome to get there. But I think that you can develop a hybrid model. I don't think it's at all an either or type thing, but REAIM can kind of focus on where you want to get, and I think the improvement model can focus on how do you get there.
Thank you.
Yeah.
Hi, thank you both. I'm Larry Mauch from the University of Washington, and Russ, I've been a big fan of your work, and Deb as well. When I see your names come across a page, I read it. And thanks for this talk on the implementation. I'm asking a question about the denominator issue that Deb talked about, which I think is a very big deal. And as I look at the work that's being done in collaborative integrative care, it seems to me that the models of implementation really transcend a continuum of respect or acknowledgement of the denominator. And denominator in community-oriented primary care or population-based care is defined by people in very different ways. Mm-hmm. And that has significant implications for the effectiveness of the model and the design of the model. In other words, it's one thing to look at your community as a practice and everybody that's on your books. It's another thing to look at everybody that shows up for an appointment. Those are two different denominators, for example, and I see both of those things heavily represented in the way integrated care, collaborative care is being practiced. And of course, the implications there are profound when it comes to your impact. Not impact Jürgen Unser, but impact on the population, because if you look at the entire group of people that are on your books, the subset that don't show up may largely be more ill, right? They may be more in need, and yet the demand on the practice to address those folks is represents a different mechanism or machine. So I'm wondering if you've learned anything about what practices do to deal with this and any advice. I think, and I wanted to just say, Deb, your point about the value of assessing the denominator about understanding practice need is something that adds another element of relevance to this. Thank you.
You're right. I mean, I think I completely agree with what you've said, and the data that I have shared is in people that come into the practice. I think there are some strategies for reaching out to people who don't come in that are more or less effective. Some folks just they live and they work and they practice in their communities, and they know their communities, and they know where to find the people that aren't coming in. And sometimes those are homeless people, then they may know where they hang out. Other practices try to use things like MyChart you know, and really make an effort to get everybody on my chart so they can try to reach out to folks that may not be coming in for appointments. Other practices may have panel managers that get folks on the phone that aren't coming in, that can do this screening over the phone. I'm now talking in the land of imagination, right? Because you can imagine a whole range of strategies. We didn't see these happening because I think this is, I believe this is part of the developmental piece of it, that you just, ACT was practices that were developing this model, and I think we had 11 fabulous clinics that will get to that point, but these are really good and important questions to be asking.
Again, just quickly, thank you. And I think we might have time for two more brief questions or comments. I think the key thing is just reporting on that. But you raise a great point, and being transparent about it. One thing that we recommend doing is kind of like the economists do, a sensitivity analysis to put in if you do it this way versus that way. I think we have a paper in Annals of Behavioral Medicine in 2010, I think, where we show exactly what you talked about, the impact of different denominators in a practice there to show it. So thank you very much. So,
hey Deb, I just have a couple of quick comments. The first thing for the audience, I'm Roger Kessler. When you get home, put both of these guys' names in your regular citation list so that you get every publication that they write. You will be much more informed by the process. The second thing is, Russ didn't mention that REAIM has, I don't think you mentioned, that REAIM has an excellent website. And it's something that many of us just keep visiting, and it's reaim.org, and I would certainly support that happening. My point is about screening and identification. So I don't support the idea of mental health substance abuse screening. It's a carve-out. It just is another mental health activity in a primary care setting. Russ and I and a bunch of others have been working on a project for a number of years now that looks at a medical behavioral risk screening assessment that would be easily paired with the wellness visit that patients have on an annual basis. The cool thing about it is that, yeah, it has the PHQ, it has the GAD, but it looks at sleep, it looks at sugary beverages, it looks at activity level, it looks at stress, it looks at a much broader set of dimensions that physicians embrace as part of what is medical. Therefore, it has a much greater opportunity to be implemented more broadly in a primary care practice. So I guess that's my comment.
That's a good point.
thank you. An integrated assessment for integrated care. So.
Mac Bear, just a quick comment. I'm from University of Minnesota. It just tickles me that this is the plenary that ends our 20th anniversary meeting. 20 years ago, I don't know, maybe 100 of us, 200 of us were in practices on instinct, trying to do what we thought was the right thing. We couldn't describe it. We had never had a denominator. And the people that I thought did so well came back. And the ones that we collectively irritated didn't. So we had no idea who we weren't helping. It was very convenient. I'm an optimist anyway, so we thought we were doing fine. But this is like daylight into this area. And now, 20 years later, this type of research, turning the lights on, finding out where we miss and that models are all flawed and all the things that you've just said, I'd like to capture and sort of put a chip in my head to be able to use it. And I hope it doesn't take 20-some years, or maybe 15 because you're so young, to train generations of people that know this type of approach. Because our primary care innovations, whether mental health or other, need this kind of comprehensive understanding of how to implement and reach and sustain that you have now turned the lights on with colleagues around the room. So thank you very much as a way to help us celebrate our 20th anniversary. Good, well done.
Thank you.